Hi, in this video we will demonstrate a case of ambulatory simultaneous veno-arterial extracorporeal membrane oxygenation and Impella left ventricular assist device as a bridge to heart transplantation. This patient was a 45-year-old male with a past medical history of non-ischemic cardiomyopathy with an ICD. He was admitted to the hospital after receiving frequent shocks for ventricular tachycardia, and he was found to be in VT storm. He had a cardiac echo performed which showed an LVEF of 12%, but only had mildly decreased RV function. He was placed on inotropic support and subsequently listed for heart transplant. However, subsequently, while inpatient, he experienced a VFib arrest which required CPR and external fibrillation. Unfortunately, following this event, he was found to have profound RV stunning and resultant acute kidney and hepatic injury. The decision at that time was to pursue mechanical circulatory support. The patient was taken to the operating room and cannulated for VA Ecmo. This was performed using a peripheral bifemoral approach with a 25 French multistage right femoral vein inflow cannula and a 17 French left femoral artery outflow cannula. He also had a distal perfusion catheter placed in the left SFA. Because of his poor left ventricular function, an Impella 5.5 was also placed for left ventricular unloading, and this was placed via a right axillary cut down utilizing a 10 mm gel weave graft. Because of his acute kidney and liver injury following his arrest, he was temporarily deactivated and placed on status 7. However, while cannulated on Ecmo, he was extubated and able to participate in ambulation and physical therapy. Later on, his kidney and liver issues resolved without intervention. He was able to be reactivated as a status 1. This video shows the patient able to ambulate through the halls of the hospital while on both VA Ecmo and with an Impella. Ultimately, he received a heart offer on Ecmo day 13 and was transplanted. He did experience a post-transplant AKI that resolved without intervention, as well as a case of bacteremia that was treated with antibiotics. He was then discharged to a rehab facility on post-transplant day 19 and then discharged home 1 week later. In conclusion, whenever possible, preoperative ambulation and physical therapy is paramount for patients undergoing large operations to prevent physical deconditioning and improving postoperative outcomes. Heart transplantation should be no exception to this rule. In the current era, with the current heart allocation system, most centers are utilizing temporary forms of mechanical circulatory support and Ecmo more often as a bridge to transplantation. However, most of these configurations pose a large challenge for the patient to ambulate and participate in physical therapy. In this case, we show that patients actually can ambulate using a support strategy consisting of femoral VA Ecmo as well as an axillary Impella 5.5.